You're alive. The heart is beating. You have a pulse. Excellent. Oh, PEA? Pulseless electrical activity? Not long. It depends. What is the quality of the CPR? It's all dependent on high quality CPR. Any questions about yesterday's lecture? Yes. Tropical medicine. Tropical medicine. I did my training in New Orleans, and they have, I believe, correct me if I'm wrong, but I think outside of the CDC, they have the only tropical medicine program in public health. And it stems from the history of Tulane and their involvement in malaria, actually. They had some big public health gurus back in the day that started the program. Yes. Um, I have a liberal arts degree. I went to a liberal arts college. I majored in English literature, and I really like broad perspectives. And I feel like public health is the liberal arts of medicine, right? So you can talk, for example, about genetic mutations in diseases like sickle cell anemia, but what is the epidemiology of sickle cell? Medicine deals with the patient in front of you. Public health deals with populations around you. So it gives you a more global perspective of medicine. And then, of course, the really attractive thing about public health is policy, right? As a physician, you can have an impact on your community. But if you're able to generate medical policy, you can have a profound impact on much larger populations. So that's what attracted me to it. Yeah. All right. Any other questions? So today we are going to complete our journey. Remember, we started with pharmacotherapy on Monday, giving us a foundation in the medical therapies available to us. On Tuesday, we talked about acute coronary syndrome, which is plaque rupture, leading to the complications of plaque rupture. The most common complication of plaque rupture is HFrEF. We talked about the neurohormonal cascade that is augmented in HFrEF. We talked about the different types of heart failure, HFrEF versus HFpEF, the clinical diagnosis of acute decompensated heart failure, and the physical exam findings. So now we're going to move on to the management of heart failure. So if you understand the pathophysiology, the management should be clear. There should be no surprises. So I want you to be able to identify and prevent pathologic conditions causing heart failure. We're going to review the neurohormonal modulation in heart failure, identify key guideline-based medical therapies, discuss mechanisms of management, and review cases of morbidity and mortality causes. So HFpEF. What is HFpEF? Yeah, what is that? Yeah, so normal ejection fraction is greater than 55%. In heart failure with preserved ejection fraction, the ejection fraction is preserved. So what's the problem? What's the issue with the filling? Not enough filling. What is preventing it from filling? And what does hypertrophy cause? Compliance. Correct. You've got reduction in compliance of the left ventricle. Remember, when you're young and you have a compliant ventricle, diastole is a very active process. You have compliant left ventricular walls. As you age, the ventricle becomes less compliant. It's not a squeezing problem, it's a relaxing problem. So for the same volume in the left ventricle, what's going to be the pressure? Lower or higher? Higher. Exactly. So your left ventricular end diastolic pressure is going to be higher. This is in contrast to HFrEF, which is due to an ejection problem. So the ventricle is unable to empty itself. The most common cause of HFrEF is okay, dilated cardiomyopathy is definitely on the differential, but it's not the most common. What's the most common? Um, Not eccentric hypertrophy is a sequelae of what? Too much volume. Correct. So long term, you're going to get eccentric hypertrophy. But what is the underlying etiology of HFrEF? Remember our case yesterday. What happened to our case yesterday? The guy did cocaine and he had he had an ST elevation MI. Plaque rupture is the most common cause of HFrEF. So if you have plaque rupture, you have infarction and myocardial necrosis. If you can imagine, that necrotic tissue is no longer functional, and therefore your heart function will reduce by far and away. This is what we call ischemic cardiomyopathy. You had plaque rupture, there was a STEMI. For whatever reason, you didn't get revascularized in time, the myocardium died, and your heart function suffered as a result. There are times when you see a patient and their ejection fraction is 10%. And you're like, why is your ejection fraction 10%? Sometimes they're 25 years old, 30 years old, young. No. Guess what you do? Well, you do an echo. That's how you know their ejection fraction is 10%. What's the most common cause of HFrEF? Plaque rupture. Yeah, so we still do a coronary angiogram. Coronary disease is such a common cause of HFrEF that even in the young, with profound reduction in heart function, we take a look at their coronaries because that will determine management further on. Now, let me ask you a question. Do you prefer, if your ejection fraction is 10%, let's assume your ejection fraction is 10%, but you get to choose for yourself. Do you want coronary disease or no coronary disease? What would you want for yourself? No coronary. What else? Huh? As you know, I care more about your thought process than your answer. It's very easy to just give me an answer. I'm more interested in thought processes. Huh? Okay. So if you have coronary disease, you may have more complications. What else? Dilated cardiomyopathy, stress-induced cardiomyopathy, alcoholic cardiomyopathy. There's peripartum cardiomyopathy, myocarditis. I mean, the differential diagnosis for non-ischemic cardiomyopathy is quite broad. Chagas disease, right? So whenever I see HFrEF, the first question I want is this ischemic cardiomyopathy or non-ischemic? Because as you can imagine, the management's much different, right? If you cath a 30-year-old with an ejection fraction of 10% and you see normal coronary arteries, is there any role for a stent? Is there any role for an aspirin? Is there any role for a statin? No, no. So when you cath these individuals and they have normal coronaries, none of the typical modalities of treatment that we use for the ischemics are relevant in the non-ischemics. So which one would you want for yourself? Coronary disease or normal coronary arteries? Still normal coronary arteries. Okay. How is it easier to treat when the coronary arteries are normal? Tell me how. Do you think heart transplantation is easy? Okay. There you go. There you go. When you find an LAD plaque, revascularization is a major option. You restore blood flow, put them on aspirin, statin, beta blocker, and the hope is that once you restore the blood flow, the heart function returns. In non-ischemics, there is no good option for treatment. Every single modality, reperfusion therapy, aspirin, statin, those are off the table. So the non-ischemics are much more complicated. And many times we don't really get to the answer. Sometimes we do. Sometimes it's more clear-cut than others. But other times it's not. Does this make sense? the most common cause of HFrEF, acute coronary syndrome, ischemic cardiomyopathy. So, HFpEF, compliance issue, HFrEF, ejection issue. So, you take that guy, 30 years old, EF of 10%, cath them, normal coronaries. So, echo. Yesterday we talked about the role of an echocardiogram. Do you need an echo to diagnose acute decompensated heart failure? Absolutely not. How do you diagnose it? Clinical presentation, correct. However, you need an echo to differentiate between HFrEF and HFpEF. Once you get that answer, in our case that I'm proposing to you, you cath the individual, normal coronaries, so the reduction in heart function is not due to a blood supply mismatch. You've now removed a major cause of HFrEF from your differential. Typically afterwards, what we do is we get a cardiac MRI. What's the difference between an MRI and an echo? I mean, a cardiac cath. Tissue. Angiography just gives you a look at the blood supply. An MRI will actually take a look at the myocardium, at the tissue. Infiltrative cardiomyopathy, myocarditis, right? There are many different entities that cause fibrosis of the myocardium. Cardiac MRI. A CT. What kind of CT? A cardiac CT. So a cardiac CT will give you the same information as a coronary angiogram. Okay? But it's less invasive, but it's radiation and contrast. Different, yeah, but different type of contrast. But a cardiac CT will not give you a look of the tissue. A cardiac CT will give you the coronary anatomy. So if you were to be like, hey, I want a cardiac CT, what would I do? I would beta block you until your heart rate is down to 50, increasing diastolic filling time, inject contrast, and then your coronary vessels fill with contrast, and I put you through a CT scanner. And then I can tell you what your LAD looks like, your circumflex looks like, your RCA looks like. I can get the entire coronary anatomy, but I won't get any information about the myocardium. Cardiac MRI is really about the myocardium. What? Correct. Correct. So, causes of death, HFpEF versus HFrEF. Most individuals, almost 50%, die of non-cardiovascular diseases. HFrEF, only 36%. Does that surprise you? Why does that surprise you? Well, if someone has heart failure with reduced ejection fraction, what's the most common cause of HFrEF? Yeah, so they already have coronary disease, right? The complication rate and their death rate from cardiovascular disease is going to be higher since they already have well-established cardiovascular disease, right? Here's the other thing. What's the most common complication of HFrEF? Well, it is heart failure. How do they die? Huh? Stroke? Not a stroke. No, not a heart attack. Although they can have recurrent heart attacks. If you infarct your myocardium, that myocardium becomes necrotic. With necrosis comes fibrosis. Is fibrosis good or bad? Arrhythmias. Arrhythmias. What kind of arrhythmias? Huh? Ventricular tachycardia. Ventricular tachycardia. Or ventricular fibrillation. The greater the degree of fibrosis, the greater the scar burden, the lower the ejection fraction, the greater the risk of cardiac arrest. This is why these individuals, what do we put in them? To protect them from arrhythmias. Not a pacemaker. All of them are on beta blockers for sure. But if someone goes into VFib arrest, defibrillator, implantable, yeah. It's got a battery this size, and it has a lead in the ventricle, and it just waits. And the moment they go into VT or ventricular fibrillation, charge, and then boom, delivers electricity. The ejection fraction 35% or less is really a key number. If they have a left ventricular ejection fraction less than 35%, they need a defibrillator. Before you put them on a defibrillator, though, you have to make sure you have maximized medical therapy. Medical therapy, beta blockers, ARBs, aldosterone. You have to maximize medical therapy. Okay? So this is to show you that HFpEF, half of them die of non-cardiovascular issues, a third of them die of cardiovascular issues. In HFrEF, almost half of them die of cardiovascular issues, and a third of them non-cardiovascular issues. Medical therapy. This is for HFrEF, medical therapy. You have to know this pathway. Angiotensinogen to angiotensin 1 to angiotensin 2 to aldosterone. Aldosterone increases sodium and water reabsorption, thereby increasing volume and thereby increasing preload. Angiotensin 2 is a profound vasoconstrictor, thereby increasing afterload. Therefore, it should come as no surprise to you that aldosterone and angiotensin 2 are key targets of inhibition. If you inhibit angiotensin 2, what are you doing? Yeah, reducing preload and afterload, both of which are beneficial. All of these are sites that you want to inhibit. ACE inhibitors, you look at the literature about medical therapy and HFrEF, ACE inhibitors, profound, decades of literature about the benefits in HFrEF. In 1986, they did the VHF trial, demonstrated that trends towards better survival with isosorbide dinitrate and hydralazine versus placebo. Nitrates reduce preload, hydralazine reduces afterload. Side effect of hydralazine? Drug-induced lupus. How do you diagnose it? Antihistone. What else? Oh, those are the symptoms of drug-induced lupus. What are the other side effects of hydralazine? Orthostatic hypotension and reflex tachycardia. Reflex tachycardia. What's the drug that causes profound hypotension and bradycardia? Clonidine. Clonidine, alpha-2 agonist. In 1987, they did a consensus trial, found that ACE inhibitors in New York Heart Association class 4 patients produced 31% reduction in death at 6 months. In 1991, they found that 16% reduction in mortality with significant decreases in cardiovascular death and hospitalization in New York Heart Association class 2, 3, and 4, and an ejection fraction less than 35%. So back in the 80s, they started to see a benefit with ACE inhibitors. In 1992, they studied ACE inhibitors in patients that had no evidence of clinical heart failure. The only thing they had was HFrEF. And look, deaths or hospitalization, enalapril versus placebo, in both death or heart failure, significantly reduced. And when do the curves start to separate? Pretty early on. This was the first clue that we had that these pathways were beneficial. Blocking these pathways were beneficial. They did a pooled analysis of 34 randomized controlled trials of various ACE inhibitors. 23% overall reduction in mortality, 35% reduction in mortality or hospitalization. Consistent across all subgroups. Again, with ejection fraction less than 25%. HFrEF. We are talking about HFrEF. Older studies do not reflect modern clinical practice as other technologies for heart failure have changed, and clinical trials included enalapril, ramipril, captopril, pril, ACE inhibitors. What are ARBs? Huh? ACE inhibitors, yes. Yes. Yeah, because this was they took a look at all the 34 randomized controlled trials that used ACE inhibitors. All of the ACE inhibitors that they used. ARBs. Know what drug is an ARB? Sartan, losartan, valsartan, olmesartan. Good. Do we use ACEs and ARBs together? No. Outcomes with ACE inhibitors, you can clearly see mortality is less and hospitalization is less with ACE versus placebo. Listen to me very carefully. These medications block hormone concentration in a dose-dependent manner. Let me repeat that. ACEs, ARBs, beta blockers, they reduce the hormone concentration in a dose-dependent manner. What do I mean by that? No. You don't want to switch treatment. What do you want to do? What do I mean that I'm telling you it's dose dependent? What do I mean by that? Why do you want to maximize the dose? What's that? I didn't catch the last part. Correct. So low dose lisinopril will give you how much inhibition of angiotensin 2 versus high dose? Less. Less. So the higher the dose, the greater the hormonal inhibition. Does this make sense? The reason why this is important is take a look at this slide. This is from 1990. These are patients with HFrEF, and look at the hormone levels in the patients that were survivors versus the patients that had died. What's the epinephrine level in the death group versus the survivors? What's the norepinephrine dose concentration? Higher. Angiotensin 2. Aldosterone. So people who are dying of HFrEF have higher circulating concentrations of these hormones. So we start low, but we very quickly escalate the dose. Because the lower I can block these hormonal pathways, the greater the outcome. You have to understand this. As little as possible. As little as possible. And I'll tell you why. Assume someone comes in with plaque rupture. 50-year-old guy, substernal chest pain radiating up the jaw. You're like, oh, unstable angina. What's the first test you do? ECG. Chest pain, ECG. You do a 12-lead ECG, ST elevation in V1, V2, V3. Where's your lesion? LAD. LAD. V1, V2, V3, anteroseptal LAD. To the cath lab. Cath lab, revascularize, comes out of the cath lab, ejection fractions 20%. The patient's hypertensive, tachycardic. Why do you think they're hypertensive and tachycardic? Those hormones, right? EF is 20%. He was a late presenter. You're going to have scar and fibrosis start to develop. In these patients, we start medical therapy immediately. Immediately. To your question, how quickly do you have to get them on high doses? Well, let me give you a scenario. In this case, you have 90 days after revascularization to repeat another echo. 90 days. If in 90 days the ejection fraction has not recovered greater than 35%, they get a defibrillator. And you do not want to put in a defibrillator if you don't have to. Outcome is much better when the ejection fraction is higher. The lower the ejection fraction, the worse the outcome. That should make sense. That 35% mark is a key mark for us because in patients with an ejection fraction less than 35%, the infarct size is so great that the likelihood of them dying of ventricular arrhythmias is high. We don't measure hormone levels, ejection fraction. So we, in the hospital, when they come in, we start medical therapy very aggressively. We start targeting, unless if they're in cardiogenic shock, well, okay, we're not. But outside of cardiogenic shock, we're starting beta blockers, ACEs and ARBs, and spironolactone or aldactone very quickly post revascularization. You have 90 days from revascularization to repeat another echo. And they better be on optimal medical therapy at the highest tolerated dose. Why? It's a neurohormonal modulation. Everything that we do in the medical therapy of HFrEF is trying to modulate neurohormones. ACEs or ARBs, beta blocker, aldosterone inhibitor. So we always start low and we very quickly escalate. Again, remember from Pharmacology Monday, ACEs, follow the creatinine. You're allowed up to 30% bump in your creatinine, hyperkalemia, cough, bradykinin, induced cough, angioedema. Pregnancy is a contraindication to ACEs and ARBs. No pregnancy, no breastfeeding, nothing. And obviously hypotension. ARBs. Data's pretty good too. Data's fantastic. EF less than 40% with heart failure symptoms, 20% reduction in mortality, almost 40% decrease in hospitalization. Addition of ARBs to ACE inhibitor therapy. Addition of Valsartan to ACE inhibitors did not reduce mortality, but did reduce heart failure hospitalization. But the risk did not outweigh the benefits. Candesartan added to ACE inhibitors reduced cardiovascular mortality and hospitalization, but with higher risks of adverse events. ARBs versus ACEs. There is no difference in mortality in patients greater than 60 with New York Heart Association symptoms and an ejection fraction less than 40%. Okay? Beta blockers. Why do you want to beta block these individuals? To reduce heart rate, that's one reason. By reducing heart rate, you're increasing coronary perfusion. What else? Huh? Yeah, which hormones are you blocking? Epinephrine and norepinephrine, the catecholamine pathway. What are the three beta blockers with known reduction in mortality in HFrEF? Metoprolol succinate, carvedilol, bisoprolol. Low dose, medium dose, or high dose? High dose. Start low and very quickly go up. I want you to memorize this. I don't care if you memorize the numbers. Take a look at the hormone concentration. Higher the concentration, greater the mortality. You have to know this. The syndrome yesterday that we were talking about is this activation of these neurohormonal cascade. That's the syndrome. Everything we are trying to do in acute coronary syndrome, everything you were trying to do was trying to prevent thrombosis. Here in HFrEF, you're trying to prevent the neurohormonal cascade. Every single branch must be inhibited. Okay? It's a negative inotrope. That's a good thing. It reduces oxygen demand. The circulating neurohormones are augmented in HFrEF. So therefore, they block it. And these are just the beta 1, beta 2, alpha 1, alpha 2. Metoprolol succinate, selective or non-selective? Selective. Good. So, I'm not going to read this slide. The evidence is robust. Okay? The evidence for beta blockers are robust. Carvedilol, metoprolol succinate, and bisoprolol. In 2003, there was a trial called the Comet HF trial, 17% reduction in mortality in carvedilol versus metoprolol tartrate. Do not use metoprolol tartrate. Don't do it. There's no evidence for tartrate. Look at this. Low dose, medium dose, high dose of carvedilol. Compare the low dose to high dose. Greater ejection fraction improvement, but take a look at the mortality rate. 6% versus 1.1%. Maximize the dose. How? How am I monitoring them? Echo. Echo. Just keep on going up. But doctor, patient's blood pressure is 105/60. Do you really want me to up-titrate the medication? Yes. Why? Not all of them. Metoprolol succinate, bisoprolol, but carvedilol is not. ACEs and ARBs. Do you really want to go up on the ACE inhibitor? The poor woman, 65 years old. Correct. I don't care what the blood pressure is. My entire focus is the neurohormonal cascade. So if someone comes up to me and says, "Oh, I don't feel comfortable giving the medication," patient's blood pressure is too low. Too low. That's what they think. 105 over 60 is too low. My question is the patient symptomatic? Is the patient lightheaded, dizzy, passing out? Why is that important to ask? Because if they're not symptomatic, why would I withhold life-saving medications? What complications are you? I mean, yeah, hypotension is a problem. So unless, I mean, assume I start them on a beta blocker, an ACE inhibitor, aldactone, and then the patient's getting orthostatic. Their blood pressure is dropping 30 points when they stand up. You have my attention. So that's a symptom. Okay, I'll back off. Sure. And I'll document exactly what happened. I gave Mrs. So-and-so this dose of a beta blocker, this dose of spironolactone, this dose of lisinopril, and blood pressure dropped to 60 over 40, and she became lightheaded and dizzy. Orthostatic hypotension. Okay. The evidence for these drugs is so strong that you have to document why they are not on it. Can you believe that? You have to document why they are not on it. And we routinely get audited. Both. Both. Hospitals audit themselves because they don't want the ramifications of an audit nationally. Take home points. We start beta blockers very quickly. Okay? Again, they need to have a blood pressure, right? If they're in cardiogenic shock, don't start them. We start low and we very quickly titrate upward. We use heart rate as an adjunct for effective therapy, right? How do I know if I'm maximizing beta blockade? I look to the heart rate. Is the resting heart rate 50? No, go up. If the patient is ambulating and their heart rate goes from 60 to 90, go up. Use evidence-based beta blockers. There is this bronchospasm in non-selective beta blockers if someone is having an active COPD or asthma exacerbation, they're wheezing, don't put them on a beta blocker. But asthma and COPD are not contraindications. So I hope I have convinced you that you must block these neurohormonal cascades. If I have not, I have not done my job. But remember from yesterday's talk, look at all of the hormonal cascades that we are trying to block on the right-hand side. Every single one of those, epinephrine, norepinephrine, beta blockers, renin-angiotensin, ACEs or ARBs, and aldosterone, right? Spironolactone or aldactone, in a dose-dependent manner. The real excitement in the past few years, though, is on these new cascades of hormones that actually are beneficial. And I alluded to this yesterday. Natriuretic peptides. Natriuretic peptides cause what? What is it? They're natural diuretics, and they're released in response to stretch, myocardial stretch. Right. So they cause diuresis and vasodilation. So you don't want to inhibit natriuretic peptides. What do you want to do? You want to augment. So once we saw that there was this correlation, everyone started focusing on ways to augment this. Look, vasodilation, diuresis, it inhibits fibrosis, and aldosterone suppression. So this, they realized in BNP, the precursor of BNP is pro-BNP. It gets cleaved to BNP and anti-pro-BNP, which is inert. The BNP is what you want, right? That's the natriuretic peptide. In the body, there is a hormone called neprilysin. And guess what neprilysin does? It destroys BNP. So what do you want to do to neprilysin? Inhibit it. And lo and behold, came the era of neprilysin inhibitors. Neprilysin inhibition increases BNP levels. This is a pivotal trial. And these pharmaceutical companies are so smart. Once you realize how to augment natriuretic peptides, they combined it with a class of drug that inhibited the harmful neurohormonal cascade with which the evidence was already robust. And guess what they chose? Valsartan. What's the class of drug? ARBs. Decades of solid literature behind ARBs already. So, sacubitril is the neprilysin inhibitor, and they combined it with valsartan. The trade name is Entresto. You don't have to know that. If you hear it, there's commercials all over television. Entresto. Ask your doctor about Entresto, right? It's a neprilysin inhibitor. So when they took sacubitril and valsartan and they compared it to enalapril, which is a ACE inhibitor, with ejection fraction less than 40% in symptomatic heart failure patients, they looked at cardiovascular death and heart failure hospitalization, 21.8% versus 26.5%. They had a 20% reduction in cardiovascular death and 16% reduction in all-cause mortality. The crazy thing about this was the side effect profile was no different than ACEs and ARBs. So no change in side effect with better outcomes? You're not wrong, right? We obviously avoid in patients with a history of angioedema in ACEs and ARBs, since it contains an ARB. Finally, aldosterone antagonists, usually in severe symptomatic heart failure patients, class 3 and 4, the RAILS trial led to 30% reduction in mortality in patients with ejection fraction less than 35%. In 2003, they looked at eplerenone which led to 13% reduction in mortality in post myocardial infarction patients with heart failure symptoms or with patients with diabetes. Okay? Long story short, we start aldosterone inhibitors with good data in patients with HFrEF. Vasodilators. Nitrates and hydralazine. Nitrates and hydralazine. So what do you think is the benefits of combining nitrates with hydralazine? So is hydralazine, what's the mechanism of action of hydralazine? Vasodilator. So what does it do to afterload? It decreases it. What do nitrates do? Decrease preload. No. No. Hydralazine reduces afterload. It's a arterial vasodilator. Nitrates is a venodilator. So when you dilate the venous system, what are you doing to preload? Decreasing it. Two medications, dropping afterload, dropping preload. Can you name of one medication that does the same? Remember the renin-angiotensin pathway? N? No. ACE inhibitors. ARBs. Guess which ones did better? Pick the other one. Yeah. Huh? Inhibition of this pathway? Why isn't the outcome with nitrates and hydralazine as good as ACEs or ARBs? This is attacking the neurohormonal pathway. It's not about afterload and it's not about preload. Hydralazine is a smooth muscle vasodilator that is outside the mechanism of angiotensin II. Nitrates expands the venous capacitance, but does nothing with aldosterone. Does this make sense? There are some patients who are on maximal ACEs and ARBs, maximum dose, and they're still hypertensive. Okay. Hydralazine, nitrates, as long as they're on maximal medical therapy on the proven medication classes, no problem. Okay? But they do not replace ACEs and ARBs. It should come as no surprise. Yes. All for what? Whoa, 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 whoa. You never give ACEs and ARBs together. Have I not made that perfectly clear? ACEs and ARBs, remember that slide. No change in outcome, greater adverse effects. Right? Never give ACEs and ARBs together. Ever. In your mind, they're the same class. Even in our hypertension lecture, I put ACEs slash ARBs. Same, for your purposes, same class. And don't ever use them together. There is no clinical scenario that you can say both of them should be given together. Thank you for that. I have not made myself clear. Yeah. What's the side effect? Sure. Absolutely. In fact, in my medical practice, I never use ACE inhibitors. Losartan has no cough, right? I'm so tired of dealing with cough. And oh, I think it's giving me a cough. I just remove it. For hypertension, losartan is my drug of choice. So that's number one. Number two, in patients with HFrEF, guess what Sacubitril-Valsartan has done with the use of ACE inhibitors? It's replaced them. There is no role for ACE inhibitors anymore because of sacubitril-valsartan. In fact, if someone is on lisinopril or an ACE inhibitor, and I want to switch them to sacubitril-valsartan, I stop the ACE inhibitor and I wait 36 hours to let it leave their system before I start sacubitril-valsartan. Sacubitril-valsartan is only indicated with HFrEF. There is no role for hypertension. Sacubitril-valsartan is only for HFrEF. What time is it? 9:05. Any other questions? Do not use ACEs and ARBs together. There is no indication. So, the pillars of heart failure therapy, there's 4 of them. And they're all hormonal. Number 1. Huh? No. Medical therapies. ARBs? Yeah. So neprilysin inhibitor and valsartan. That's 1. Beta blockers. That's 2. MRA. That's 3. What's MRA? Receptor antagonist. Correct. So spironolactone for the aldosterone side. So that's 1, that's 2, that's 3. And then the fourth one, it's actually no. The fourth one is the new kid on the block, SGLT2 inhibitors. Yeah, SGLT2 inhibitors. You know, I think SGLT2 inhibitors right now for you guys, it's not ready for prime time. I don't even think in your books. It's already in there? Oh, it's there? Oh, wow, they move fast. Yeah. So SGLT2 inhibitors, game changer. Game changer. The mechanism of action, there's still a lot of hand waving going on, right? It actually used to be, it's classically a diabetes medication, right? There's vasodilation, there's diuresis. So they're still beginning to tease out exactly what the mechanism of action is. But they realized in non-diabetics, this traditional diabetes drug has mortality benefit. There is some caveat to it in the elderly. They tend to get really bad urinary tract infections. So if there's someone with like a chronic indwelling catheter, history of recurrent UTIs, or something like that, we don't like to use it. But that's the fourth pillar, SGLT2 inhibitors. So anytime you go see someone, if someone has HFrEF and they come into my office, I look at all those 4 pillars and I ask myself, are those 4 classes being prescribed? And what's the dose? If they're not on maximally tolerated dose, guess what I do? Increase it. No, because we use SGLT2 inhibitors in non-diabetics as well, right? So they may even be on insulin. So the management of their diabetes continues. In fact, and this is outside the scope of this talk, and this is outside the scope of what you're expected to know, but the dose of the SGLT2 inhibitor is different in patients with HFrEF and with diabetes. The dose is different. It's a lower dose with HFrEF. You don't have to know that, but you asked the question. So, for example, the diabetes could be rampant. It could be uncontrolled. They may require insulin. That's still not a contraindication for SGLT2 inhibitors. Any questions? I'm so happy to hear that SGLT2 inhibitors are already in your material. I got to put that in my slides. All right. Tachycardia is bad. Bottom line, tachycardia is bad in these patients. So you maximize your beta blocker, be it bisoprolol, metoprolol, succinate, or carvedilol. But in some patients, they're still tachycardic despite maximal beta blockade. There's a interesting drug, ivabradine, that we add in addition to beta blockers. It decreases heart failure, hospitalization, or death by 18% in patients with HFrEF, and they still have resting heart rates greater than 70 and they've been hospitalized for heart failure within a year. Patients in the highest heart rate group had a 2 times increase in composite outcome relative to those in lower heart rate groups. So baseline elevated heart rates is a manifestation of this catecholamine surge that they have. So this is a drug we add in addition to beta blockers. Digoxin, more historic than anything else. This is a mechanism of action that you should know. Actually, the use for digoxin in atrial fibrillation is probably much more relevant than in patients with HFrEF. We really no longer use digoxin in the management of HFrEF because of all of the great agents we have that we just talked about. HFpEF therapies? When I was in your shoes, the only therapy we had in HFpEF is treat underlying comorbid conditions. If they're hypertensive, treat their hypertension. If they're diabetic, make sure their diabetes is under control. If they have coronary disease, make sure their LDL is under control. But now, SGLT2 inhibitors. SGLT2 inhibitors. I always make sure that blood pressure is under control, heart rate's under control, diabetes is under control. Just because remember, these are patients with just a stiffened ventricle that you don't want them hospitalized. High blood pressure in a concentric ventricle is bad, right? At baseline is bad. SGLT2 inhibitors is now one of the agents that we use in HFpEF. I'm going to update this now for you guys. SGLT2 inhibitors. The last thing is salt. Salt. I had lunch with some of you guys a couple of days ago, and you were having the cafeteria food downstairs, loaded with salt. I promise you that mac and cheese, the reason it tastes good is butter and salt. If I took your blood pressure 1 hour after you ate, your blood pressure would have probably been close to normal. Why? You're young. You're young. I look at you and your compliant ventricle and your compliant arteries. You're still under the warranty of youth. If I had that mac and cheese and you took my blood pressure, it would be high. I am past my plateau and I am beginning the descent into the decay of life. And with that comes compliance, the loss of compliance, right? So we are talking about entities in patients that the majority of patients with HFrEF and HFpEF are older patients, right? Compliance is a big part of the problem. So really focusing on lifestyle changes, diet, low salt, exercise is pivotal in controlling long-term outcome. It's pivotal. Every encounter that I have with a patient, I sprinkle a little bit of education. Oh, no. Some of my patients are, "Oh, what about pink salts? What about sea salts, natural Himalayan salts? Sodium chloride, sodium iodine, sodium, whatever formulation from the Himalayas, from Nepal, from the purest form of salt body of water." No, no. There are a lot of salt substitutes out there. It's interesting. Some of the salt substitutes still have salt in them. No one, this is such an issue in the United States. We put a nutritional sticker by law about serving size, salt content, fat content, and caloric content. And no one reads it. No one reads it. Sometimes a bag of potato chips, you look at it and you're like, oh, that's not too bad. It's only 25% of my daily intake. But it's like the whole bag is 8 serving sizes. It depends. How bad is your loss of compliance? How low is your ejection fraction? It depends. Lower is better. I tell my patients this. If you take a bite out of the food and it tastes good, put it down. Put it down. And the reality is, unless you make the food from scratch, you have no control over the salt content, right? Unless you tell me it's farm to table, okay. Canned ingredients, salt. Frozen ingredients, salt. Shelved ingredients, salt, right? When you enter Trader Joe's or Stop and Shop or Kroger's, whatever is in your area, stay on the outside of the pharmacy. Do not, of the supermarket. Do not go into the aisles. Don't do it. Salt. Any questions? What? Oh, my pleasure. I am now going to, let's do some questions. Drew, if I have not convinced you of this fact, I have not done my job. All right. If you understand the neurohormonal cascades, you understand HFrEF. Okay. These hormones are so consequential long term to the patients, you have to block them. Which hormones are beneficial to long term outcomes? Natriuretic peptides. Everything else you try to inhibit. Natriuretic peptides, you augment. The left ventricle's long-term adaptive response to pressure is concentric hypertrophy. Chronic hypertension? Yes. Aortic stenosis? Yes. Doesn't matter what the etiology of the pressure is, it's going to be concentric hypertrophy. The most common cause of right-sided heart failure? Left-sided heart failure. The physical exam finding with the highest positive predictive value is S3. Why? You you showed it to me. I need a better answer than that. Why is an S3 so good for acute decompensated heart failure. It's not a regurgitation sound. Okay, what does that mean? It's not contracting or relaxing. You can hear an S3 in both HFpEF and HFrEF. It's blood on blood. So an S3 is telling you the left ventricle has blood in it, in diastole. So it either is a stiffening problem or an ejection problem. So it's essentially telling you that the patient is short of breath due to elevated left-sided filling pressures. A JVD, hepatojugular reflex, there's still good clinical signs of volume overload. The only reason they're still good is because the most common cause of right-sided heart failure is still left-sided heart failure. But cor pulmonale still does it. Okay? Which are not clinical signs of right-sided heart failure? What's ascites? Fluid in the peritoneum. Huh? Lower extremity swelling, ascites, JVD, or orthopnea? Why ascites? Okay. What's your answer? It's D, orthopnea. Why? Huh? Yeah, why is it D? Yeah, pulmonary edema is a classic sign for left-sided heart failure. So when they lay down, the fluid layers over the lungs bilaterally and they get orthopnic. When they sit up, the fluid goes down, gravity, and then it exposes the upper lung fields for gas exchange. So if you hear an S3, that means you have elevated left filling pressures, an elevated LVEDP, a greater wedge pressure, and therefore you're going to have orthopnea. You're going to have pulmonary symptoms. This is the same reason why if you see pulmonary edema on a chest x-ray is so good for acute decompensated heart failure. It's another evidence of elevated left-sided pressures. JVD is before the lungs. Ascites before the lungs. Low extremity swelling before the lungs. So you may have evidence of right-sided heart failure due to, for example, cor pulmonale, but you won't have orthopnea. Beta blockers block which hormonal pathway? Sympathetic nervous system. Patient presents with dyspnea on exertion with less than ordinary activity. What is it? Less than, yes, C. New York Heart Association class 4 is Arrest. Correct. Neprilysin inhibition is? Correct. In HFpEF, therapies that reduce long-term mortality include? Huh? E, none of the above. Yes. SGLT2 inhibitors, but not neprilysin inhibition. All of the following beta blockers have proven mortality benefit in HFrEF, except tartrates. Correct. The diagnosis of acute decompensated heart failure is? All right, guys. So, thank you so much for having me this week. It's been a pleasure meeting you guys. Um, you know, there's never been a more exciting time to be in medicine right now. You're entering the field where there's so much need for good doctors, and there's a lot of great advancements. Some advice I would give you is stay curious. Think about Bloom's taxonomy. Think about the way you're studying. Ask yourself deep questions. Become experts in topics, right? Spend time dissecting one topic versus superficially understanding multiple topics. That's really critical because patients do not read the textbook, right? So your understanding of physiology, pathophysiology, and pharmacotherapy is critical. Every decision you make is going to affect the patient. And that's why, with great power comes great responsibility. I hope I have convinced you. I hope I have convinced you that the material you are studying now has profound implications when you see patients in your clinical years. Bless you. Okay. All right. It's been a great week. Thank you so much. Take care.